Hello students, today we will have discussion on hospital acquired infection. Start with the definition. So it is also called nosocomial or healthcare associated infection. So it is infection acquired in hospital by patient who was admitted to other reason. Infection was not present at time of admission and symptoms appear after 48 hours of admission. That is called as hospital acquired infection. So that means infection getting in the hospital, acquired in the hospital. So now what are the factors which give rise to hospital acquired infection? So it is immune status of the patient. So if immunity is good, then patient will not get that hospital acquired infection. So immune status of the patient, hospital environment. So cleanliness is, if it is there, then there will not be the hospital acquired infection. Then hospital organisms present in the environment. Then diagnostic and therapeutic procedures, if they are done aseptically with proper precautions, then there will be low chances of the hospital acquired infection. Then blood transfusion. So if the screening of the blood and blood product is done properly, then the chances of the blood transfusion infection is less. And then poor hospital administration. So these are the factors which give rise to hospital acquired infection. Then we'll see sources of hospital acquired infection. So there are mainly two sources, endogenous and exogenous. So endogenous means from inside the body. So that is a normal flora which become pathogenic and then give rise to infection. And then second source is exogenous, that is it is present in outside. So first in that it is hospital personnel. So they carry microorganisms and directly transmit it to patients. Then second is environment. So first is in that it is hospital air which contains microorganisms. Second is surfaces, so contaminated by patient secretions, blood, body fluids, excreta. So surfaces like bed or trolleys or furniture, then objects like bed, tables, trolley, furniture, then medical equipments like thermometers, stethoscopes, blood pressure apparatus, bedpan, urinals, spatula, needles, so etc. These are all used for the patient, and if they are contaminated, they may cause infection to the patient. So we'll see causative agents causing hospital acquired infections. So it is a escape group of microorganisms, that is Enterococcus, Staphylococcus aureus, Klebsiella pneumoniae, Acinetobacter, and Pseudomonas aeruginosa, Enterobacter. And then other microorganisms which may cause hospital acquired infection. So they are E. coli, Mycobacterium tuberculosis, Legionella pneumophila, then Candida albicans, Clostridium difficile, which causes diarrhea. Now we'll see mode of transmission of hospital acquired infection. So in that, contact, inhalation and other things are there, other mode are there. So first is contact, so it can be direct contact or indirect contact. Then inhalation, so it can be droplet. So if more than 5 micron size of the droplet is there, so that can cause in infection. And then airborne, when the size of that source is less than 5 micron. Then bloodborne, so can be because of the blood or blood products through transmission, which causes disease like HIV, hepatitis B and hepatitis C. Then next is vector-borne, so vectors can be mosquito or flies. And then common vehicle like water, food, equipments contaminated. So these are all mode of transmission of hospital acquired infection. Then we'll see types of hospital acquired infection. So here there are divided into major types and other types. So major types, it can be catheter associated urinary tract infection, central line associated bloodstream infection, ventilator associated pneumonia or surgical site infection. And then other types, it can be transfusion associated infection, healthcare associated gastroenteritis or healthcare associated tetanus. Other types of HAI, so transfusion associated infections like HIV, hepatitis B, hepatitis C. So risk of infection through blood and blood products.
So first is the definition. So it is presence of significant bacteriuria in catheterized patient with or without symptoms or signs referable to urinary tract. So significant bacteriuria means colony count should be more than 10 raised to 5 colony forming units on blood agar plate, and with or without symptoms. So if it is with symptoms, it is called significant symptomatic bacteriuria. If it is without symptoms of urinary tract like hesitancy or frequency, burning micturition, or dysuria, that is pain at the site of urination, fever. So if without symptoms, it is called as asymptomatic bacteriuria. So now we will see what are the causative agents, microbiological agents causing catheter associated urinary tract infection. So if the catheter is placed short term, then it is monomicrobial, that is single organism is involved, and it may be more prominently E. coli, and then other bacteria like Klebsiella, Serratia, Citrobacter, Enterobacter, Pseudomonas, Acinetobacter, cons, that is coagulase negative staphylococcus, enterococci, candida. Candida is a fungus. So these are seen in short term catheterization. If long term catheterization, then it is polymicrobial, that is many organisms are present at one time, and they may be these short term organisms plus other organisms like Proteus, Providentia, Morgagni. Now we will see pathogenesis. So there are mainly 4 entry points to cause the catheter associated UTI. So first it is urethral meatus and catheter junction. Then second is the drainage tube and bag junction. Third is the entry present in drainage bag, and fourth is at the outlet valve of the drainage bag. Now we will see what are the factors causing urinary tract infection. So it is divided into device related, patient related, and healthcare worker related. So first we will see device related. So in that, type of catheter is very important. So which type of catheter is used, that gives the urinary tract infection. Then type of material, whether it is latex, so it is more risky. Then patient related. So female patients are more prone for the urinary tract infection. Then if illness is present, the fever or any other infection, then it is causing urinary tract infection. Old age, that is more than 50 years of age, are more predominantly involved in UTI. Then patient having diabetes mellitus, raised serum creatinine, poor hygiene of the genital tract, or incomplete emptying. So these are the patient related factors. Then healthcare worker related factors, so either doctors or sisters or paramedical workers who are inserting that catheter, maybe they are not taking proper aseptic precautions, and that may land up in urinary tract infection. So now we will see diagnosis of CAUTI, that is catheter associated UTI. So first is a device criteria. So in that, presence of urinary catheter in a hospital environment more than 2 days. Then clinical criteria, so any one sign and symptom of the UTI, that is fever, suprapubic tenderness, urgency, so patient feels urgent to go, cannot control urination. Then frequency, so that is increased number of urination. And then dysuria, it is pain at the site of the urination. Then cultural criteria, so it is significant count is more than 10 raised to 5 per ml of the urine, it is called as significant bacteriuria. And then in that, treatment is removal of the catheter and appropriate antibiotics should be given. Now we will see sample collection. When we have to diagnose that, how to collect urine sample. So you have to disinfect the tube with the alcohol, and then from the proximal portion of the tube you can collect the urine sample. But urine sample should not be collected from the drainage bag. So sample can be collected from the sampling port after disinfection with alcohol. Then what are the documentation required? So first is indication of the catheterization, why this catheter is inserted. Then name of the healthcare worker who inserted that catheter, date and time, daily assessment for need of the catheterization, and daily catheter care should be performed, that is cleaning and emptying of the bag frequently, and then date of removal of the catheter if catheter is not required. Now we will see care bundle for urinary catheter. So what is bundle? So it is group of instructions, so it is called care bundle. So it is for the insertion of the catheterization. So it is catheter should be inserted only when it is indicated appropriately, then only sterile atoms, that is sterile catheter and other things used, then it should be non-touch technique with strict asepsis. So the sterile catheter is used and the part, that is periurethral part, is strictly cleaned. Then continuous closed drainage system should be used. Catheter of appropriate size should be used. Then catheter properly secured by plaster to plaster technique. So it should be secured over the abdomen or over the thigh, and then that drainage bag should be below the bladder level but above the floor level. The maintenance bundle. So daily what things we have to do. So daily catheter and meatal care, that is strict aseptic technique is used. After hand hygiene and single gloves is used for the single patient. Then catheter properly secured, drainage bag should be above the floor and below the bladder level, closed drainage system should be there, and collection of urine from the bag. So separate jug is there for the collection, hand hygiene done, gloves used, and then alcohol swab is used for the aseptic of the outlet. Then daily assessment of readiness of removal of the catheter must be documented. So if it is indicated for the removal, or if any sign of obstruction or infection, then removal of the catheter should be done. So this is a summary of the precautions taken to prevent urinary tract infection. So before catheterization, the person should know knowledge about the catheter type and size to be used, and only the where indicated, that is indication, should be there. Then during catheterization, gloves should be used, then hand hygiene and then gloves used. Then sterile catheter should be used. Periurethral cleaning should be done with proper aseptic precaution. Then catheter insertion should be done with 2% lignocaine. Then balloon inflation should be done and it is secured properly. Then gloves removed and hand wash done. After catheterization, closed drainage system properly maintained. The bag should be below the bladder level and above the floor level, and then emptying of the bag should be done after doing hand hygiene and using gloves, and separate jug should be there for emptying each bag, and then frequently it should be done. Over collection of the urine should not be there in the bag, and then separate container used, then hand hygiene, gloves used, alcohol swabs for the meatal care with soap and water should be done. So what is the definition? It is development of bloodstream infection in hospitalized patient which is attributed to presence of central line as a source of infection and not associated with any other causes of the bloodstream infection. So it is totally of the infection of the central line after the insertion. So classification of central line can be, it is short term less than 72 hours, long term more than 72 hours, or according to the site it can be subclavian, femoral, internal, jugular, peripheral vein. Organisms causing central line associated infection, they can be cons, coagulase negative staphylococcus, Staphylococcus aureus, gram negative bacilli, in that it can be Klebsiella, Enterobacteria, then Pseudomonas, Acinetobacter, Citrobacter, and in fungi it is Candida. So cons and Acinetobacter, these two organisms, and Pseudomonas, these organisms are more commonly isolated. The route of entry in this, it can be through the patient's skin flora because of not taken proper aseptic precaution, or the contamination through healthcare worker because of the no proper hand hygiene, or hematogenously from the other focus of infection inside patient's body, or contamination of the device. So risk factors are device associated, patient associated, or healthcare worker associated. So in device associated, it is dependent on the duration. So longer the duration, more is the risk. Then site, femoral site is more risky, so subclavian site should be preferred. Then type, non-tunneled is more risky, multi-lumen more risky, and emergency situation is more risky than the elective situation. Patient related risk factors, so it is immunodeficiency, patient may be on immunosuppressant, long term steroids, or patient is having immunodeficiency disorders or higher antibiotic use. Patient may be having illness, any hematologic malignancy, burn, psoriasis, or any distant focus of the infection in the body. Healthcare worker associated factors, it can be poor hand hygiene, lack of infection control practice, that is ICP, skin antiseptic which is used. So alcohol is more causing infection than the chlorhexidine. So chlorhexidine is a preferred antiseptic. So now we will see what the diagnosis. So according to the device criteria, the catheter should be more than 2 calendar days. Clinical criteria, there should be symptoms like fever, chills, rigors, hypotension, bradycardia, apnea. Then catheter site, you will see erythema, that is redness, tenderness, warm, and swelling will be there. And sample taken, blood sample taken, it will show positive culture report. Now we will see insertion bundle and maintenance bundle. So what precaution should be taken while insertion, and then after that the maintenance. So in insertion, first is proper hand hygiene with all the steps, then sterility should be maintained, sterile device and proper antiseptic is used with maximum PPE, that is gloves, mask, cap, apron. So all these things should be required. Then site, so subclavian site is choose because femoral is more having risk factor. Then in skin antiseptic, alcohol is more having risk factor, so chlorhexidine should be used. Then skin should be completely dry. Then semi-permeable dressing should be used, and date and time of insertion should be recorded. In maintenance bundle, daily care with hand hygiene and decontamination by alcohol should be done. Then local signs of infection like erythema, tenderness, warmth should be checked. Then change of dressing with 2% chlorhexidine should be done, and daily assessment of the removal of the catheter or central line should be seen. So it is pneumonia that occurs in 42 to 72 hours after endotracheal intubation or mechanical ventilation. It is characterized by presence of new or progressive infiltrate, sign of systemic infection, that is fever, increased total leukocyte count, worsening oxygen percentage of saturation, and changes in sputum character. In that culture is positive and the microorganisms isolated are commonly pneumococcus, acinetobacter, pseudomonas, H. influenzae, MRSA, that is methicillin resistant staphylococcus aureus, E. coli, and Klebsiella. So in microbiology, if it is early onset, in 4 days the bacteria are pneumococcus, H. influenza, MSSA, and Moraxella. MSSA is methicillin sensitive staphylococcus aureus. And if late onset, that is more than 5 days duration for the ventilator, then it is Pseudomonas aeruginosa, Acinetobacter baumannii, E. coli, Klebsiella, Serratia, and MRSA. The source may be endogenous or exogenous through air, water, equipments, or nebulization medicines. The pathogenesis is entry through the aspiration of oral gastric secretions or direct extension of infection or inhalation of aerosols, or it may be hematogenous. The risk factors are divide associated, so it is duration. If more duration, more risk for the ventilator associated pneumonia. Then re-intubation is one factor, nasogastric tube or humidifier used. Then change of ventilator circuit, aspiration of gastric fluids or aerosols, the inhalation, intracuff pressure if it is less than 20 cm of H2O, irrational use of antibiotics, or maybe patient is having stress ulcer, antagonist, antacids, sedation or tracheostomy. So these are the risk factors associated with the device. Then patient associated factors, the age more than 60 years and males are predominant. Then duration of the hospital, more the duration, more the pneumonia can happen. Then illness, like patient is having COPD, chronic obstructive pulmonary disease or ARDS. Then supine position, coma, poor nutrition, immobilization, decreased immunity, burn, sinusitis. So these are all patient related factors. Then healthcare related factors, in that improper aseptic precautions while handling the endotracheal tube or ventilator and contaminated environment. So diagnosis can be mechanical ventilator should be more than 2 days. Then symptoms, anyone like fever, hypothermia, leukocytosis or leukopenia, and culture is positive from the respiratory secretions. So these are the diagnostic criteria for ventilator associated pneumonia in hospital acquired infection. Then prevention should be, hand hygiene should be done, elevation of head 30 to 45 degree to prevent aspiration. Then oral care with chlorhexidine, that is 2% solution, should be used. Peptic ulcer prophylaxis can be by sucralfate only. Then deep vein thrombosis prophylaxis should be done, and daily assessment for the removal of the ventilator or endotracheal tube should be done. So it is infection that develops at surgical site within 30 days of surgery or 90 days of surgery of breast, cardiac or joint. The microorganisms are most commonly identified are or isolated are Staphylococcus aureus, gram-negative bacilli and anaerobes. The diagnosis is purulent pus from the surgical site or local signs of infection, and culture positive from discharge collected from the surgical site. The risk factors procedure wise, so improper surgical scrub, inadequate skin antisepsis, prolonged operation time, inadequate antimicrobial prophylaxis, poor peri-operative glycemic control, emergency procedure, pre-operative shaving. Then according to the patient criteria, age more than 60, malnutrition, diabetes mellitus or other comorbid conditions, then low immunity, MRSA carrier, duration in hospital is more, smoking, obesity, history. Then organism wise, it is bowel surgery, bacteria, viruses form biofilm. Then environment, so positive for blood clots, sutures, foreign bodies, contaminated medicines, inadequate ventilation. Classification of wound is of 4 types: class 1, class 2, class 3 and class 4. So in class 1 it is a clean wound, there is no inflammation, that is sign of inflammation like redness or swelling or temperature, no hollow viscous entered. Class 2 clean contaminated wound, hollow viscous entered. Class 3 contaminated wound, no purulent inflammation plus necrotic tissue. Then class 4 is dirty infected wound and there is sign of active infection. Classification of SSI, superficial SSI, that is skin and subcutaneous tissue involvement, and it is within 30 days. Deep SSI, muscle and facial layer is involved and it is within 30 days. And organ and space SSI, that is organ space is involved within 30 days. So prevention of SSI, so first is pre-operative prevention. So in that pre-operative bathing of the patient should be done with help of antimicrobial soap. Then MRSA carrier for the patients, then mupirocin ointment is used. Then hair removal should be done by clipper, not shaving is not done. Intraoperative, so So SAP, that is surgical antimicrobial prophylaxis, is there. So it is should be given 60 to 120 minutes before incision, and antibiotics used can be cefazolin or cefuroxime. Then single dose should be there, or if surgery is more than 4 hours or surgeries like cardiac surgery or where extensive blood loss is there, dose can be repeated. Then surgical hand disinfection with antimicrobial soap or chlorhexidine or alcohol based hand rub should be there. Then surgical site preparation, it should be by alcohol based chlorhexidine or antiseptic solution used for the surgical site preparation. Then perioperative, there is maintenance of the oxygen, that is 80% FiO2. Temperature should be normal. Blood sugar level should be less than 200 mg/cent. There normovolemia and nutritional support should be there. In post-operative wound dressing, daily with hand hygiene and gloves. So while doing dressing, hand hygiene should be done first, and then gloves wear, and then the dressing should be done. Then OT disinfection should be there with high level disinfection in surgery and in between surgery and at the end. Then periodic monitoring of air quality in operation theatre. There is no air exchanges, temperature, humidity, pressure, microbial contamination all should be monitored. And then prolongation of the antibiotic prophylaxis not recommended because of the antibiotic resistance.
Hope you find this session useful for your understanding and for your exams. Thank you.